Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article Comorbidities and Risk of Chemotherapy-Induced Peripheral Neuropathy among Participants 65 or older in SWOG clinical trials by Hirschman et al. My name is Judith Pace, and I am the Director of the Cancer Pain Program in the Division of Hematology Oncology at Northwestern University Feinberg School of Medicine in Chicago, Illinois. My oncologic specialty is cancer pain management. Chemotherapy-induced peripheral neuropathy, or CIPN, is a serious treatment-induced toxicity associated with significant morbidity. People experiencing this toxicity report limited activities of daily living due to altered sensations and pain, increased risk of falls due to diminished proprioception, and significantly impaired quality of life. This toxicity can also lessen the potential for cure when chemotherapy doses require reduction due to the presence of neuropathy. The prevalence of chemotherapy-induced peripheral neuropathy is increasing as greater numbers of neurotoxic agents are introduced and as patients live longer with the consequences of neuropathy. In a recent systematic review of 31 studies with data from 4,179 patients, the prevalence of CIPN was 68.1% in the first month after chemotherapy, 60% at 3 months, and 30% at 6 months or later. Few treatments have been found to be effective in prevention or treatment of this toxicity. A 2014 American Society of Clinical Oncology clinical practice guideline led by Dr. Hirschman, the same principal investigator of the study that is the subject of this podcast, found insufficient evidence to recommend any agent for prevention and few interventions available to treat chemotherapy-induced peripheral neuropathy. In the absence of effective prevention and treatment strategies, identification of those at greatest risk for this toxicity is crucial to limiting adverse outcomes. In the face of elevated risk, dose modification or selection of an alternative feasible treatment regimen may be employed. As noted by the authors of this guideline, current trials that evaluate risk, limited by small sample size, representation from a single institution, or retrospective designs, have produced inconsistent results. To overcome these obstacles, in the paper accompanying this podcast, Hirschman and colleagues have used a novel methodology to explore risk factors for CIPN associated with taxanes, with the aim to assist decision-making and elucidate mechanisms underlying this toxicity. This innovative approach employed study data from the National Clinical Trials Consortium SWOG and linked this with Medicare claims data to derive a robust sample size of 1,401 subjects, as well as enhanced information about comorbid disease conditions. The statistical methods carefully controlled for the heterogeneity of studies through stratification by treatment type. Additionally, the prevalence of neuropathy was examined in a control group of patients who did not receive taxanes or platinum treatment. Although there are several limitations associated with this technique, notably the absence of younger subjects, due to the nature of the Medicare data set, this creative methodology should be employed promptly in studies of other agents known to be neurotoxic, notably but not exclusively oxaliplatin and bortezomib. The creative use of this big data may help unmask the minute cellular changes within neurons and other structures that lead to CIPN. Although the association between increased risk of neuropathy in those with diabetes is unsurprising, the reduced risk of CIPN in those with autoimmune disorders is provocative. In the present study, subjects with Sjogren's syndrome, lupus, rheumatoid arthritis, and scleroderma had significantly lowered risk of developing peripheral neuropathy. This intriguing association supports an evolving line of investigation into the neuroimmune mechanisms of chemotherapy-induced peripheral neuropathy. Cytokines, including tumor necrosis factor alpha and IL-1 beta, released by immune cells as well as glia and neurons, sensitize nociceptors and enhance pain signaling. Cytokines can also indirectly lead to a host of inflammation-related responses, such as the release of bradykinin, serotonin, and histamine, and can activate apoptotic pathways within cells to contribute to pain. Several chemotherapeutic agents associated with neurotoxicity, including the taxanes, are known to induce cytokine synthesis, which is mediated by an agonist effect at toll-like receptors. The toll-like receptors are crucial to the innate immune response and more recently have been found to be involved in pain. How do these complex mechanisms relate to the protective effect seen for those with an autoimmune disease? This shared mechanism of dysregulation of cytokines may play a role in the underlying pathophysiology of both chemotherapy-induced peripheral neuropathy and the autoimmune disorders. Alternatively, the patients with an autoimmune disorder might have received or are currently receiving treatment that might mitigate their primary disease as well as the neurotoxicity associated with chemotherapeutics. Much work is needed to further investigate these biologic mechanisms. The results of this present study will inform bench work in a perfect representation of translational science, demonstrating the need to integrate findings from the bedside to the bench to the community. The confirmation of diabetes as a risk factor serves as an important guide to clinical practice. In the absence of reasonable, alternative, non-neurotoxic treatments in the person with diabetes, careful attention to diet, healthy weight, and exercise, along with smoking cessation, are warranted. Aggressive monitoring of hemoglobin A1C and medication management when levels are consistently elevated are also essential. Preventing complications of diabetes, such as foot ulcers, is particularly challenging in the face of altered sensitivity due to neuropathy. Referrals for dietary advice, physical therapy, and podiatry can be of benefit. These efforts require close collaboration between oncology teams with primary care clinicians. The study demonstrates an important limitation of the sensitivity of the existing grading system. It is surprising that only one patient in such a large sample size reported grade 4 neuropathy, as oncologists typically see many more individuals with permanent or disabling symptoms. These findings demonstrate a lack of sensitivity of the existing grading system, or possibly the emphasis on the clinician's evaluation of the patient's response rather than the patient's reported assessment of the degree of their impairment. Additional research is urgently needed in our understanding of chemotherapy-induced peripheral neuropathy. The investigators of this study should be congratulated on this important contribution, answering clinical questions about risk factors and providing a signal for future work exploring immune mechanisms of this serious and often disabling toxicity. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.